So good morning, good afternoon, or good evening, depending from where you are joining us. Tonight, the IVPN NeuroPsychiatry is back after 8 weeks of summer vacation with a mental health educational activity entitled 2021 Mental Health Pharmacotherapy in a Quick Review. During this educational activity, our top-notch psychiatry experts will share with you all the updates in the management of schizophrenia and resistant depression. In fact, major depressive disorder affects almost 300 million people of all ages worldwide. And about 1/3 of those patients diagnosed with major depressive disorder do not respond to the currently available treatment. In 2019, the FDA approved esketamine nasal spray for treatment-resistant depression. Moreover, recently, in September 2021, the FDA also approved a long-acting atypical antipsychotic, paliperidone palmitate, a one-of-a-kind, twice-yearly injectable for the treatment of adults with schizophrenia. Therefore, our webinar entitled 2021 Pharmacotherapy in Mental Health will discuss all those new therapies that were approved last year for the treatment of schizophrenia and resistant depression, but will not be only limited to only these medication, and will discuss much more therapeutic options. Before starting, let me thank Jensen for sponsoring this educational activity. In our first session, Dr. Mazen Jabr will give us an overview about the pharmacology of depression and schizophrenia in general. Dr. Jabr is a clinical pharmacy specialist in neurology and psychiatry at the Parkinson Memory and Movement Disorder Center of Notre Dame de Secours University Medical Center in Byblos, Lebanon, and was an adjunct clinical faculty at the School of Pharmacy of the Lebanese American University for more than 13 years. He holds a bachelor degree in biology, pharmacy, a doctorate degree in pharmacy, and an American board certification in psychiatric pharmacy. He is a clinician at the center with more than 20 years of expertise in the management of movement disorders, memory disorders, neurology, and psychiatric diseases, as well as deep brain stimulation for the management of movement disorders. He authored a number of publications in neurology and movement disorder in international peer-reviewed and specialized medical journal and book chapters. He was a speaker at many national and international neurology, psychiatry, pharmacy, and nursing meetings, and at local and regional TV and radio shows as part of his outreach services. Dr. Jabr, it's our pleasure to have you as a speaker with us tonight. Welcome, and the floor is yours. You can start, Dr. Jabr, your presentation, and please don't forget to unmute yourself.
Hello, everybody. Can you see me now?
Yeah.
Thank you. Thank you for giving me this privilege to be with you today. Thanks to you, Dr. Zainidine, and to everybody, to everyone involved in this interesting webinar. Today, I'll give you just an overview of what's been known in depression and schizophrenia. First, I will start by by a general overview of and present it. How does they show clinically? What do we have in hands as far as treatment? What's we still in need, and what's new, whether in the market or in the pipeline. Whether people deny it, accept it, or whatever they want to consider it, mental disorders are there. Mental disorders are here to disable us. And this is what has been shown in the global burden of study that was recently released in maybe 3 years ago, and showed among the mental disorders to what extent depressive disorders and anxiety disorders occupy, how much they occupy and cause disability in our life. Schizophrenia may come next, but we cannot underestimate psychosis as an entity and how much problem it may cause. This is all it was in 2019. We cannot underestimate the pandemic of COVID-19 and how much of this has been changed since then. Yet, the news will come after a few years, after an update of this study. I'll start by depression. Depression, who did not have it or experienced at least some of its symptoms? Yes, as you may all know, it's been diagnosed, usually diagnosed through DSM-5 criteria. We have to fit some of these criteria, but clinically patients show or report endless number of symptoms. Actually, in one of the studies that mathematically calculated this, they showed that we have at least more than 10,300 types of symptoms that patient may show and report symptoms of depression. And the most commonly usable scales, I name here, maybe we have about 7, they evaluate no less than 50 symptoms. Not to mention that we have subtypes of depression: psychotic, anxiety with depression, catatonic, and we have postpartum depression. So we have subtypes. So it seems a little bit illogical to think that such a really heterogeneous problem can have one etiology. But that's why we thought about different mechanisms underlying the depression. And we cannot think of just one mechanism, but rather an interplay between all of these mechanisms doing the work together to show the different semiology and different presentations of different types and subtypes of depression and all its presentations. In the early 50s, it was found that the depletion of monoamines was at the basis of seeing symptoms of depression in some of the patients. Just replenishing them was enough to make them feel better. And from that started the monoaminergic hypothesis. And since then, a lot has been done based on this hypothesis. And things started by just trying to replenish these monoamines. I mean, serotonin, dopamine, norepinephrine, and even melatonin. So, and things have started from there. But the problem is that the point is that just not replenishing either by inhibiting their breakdown or they're inhibiting the transporter of these synaptic transporter of these monoamines. The point is that they do not make the point is not there. There is other cascade of events that may lead to improvement of depression, of symptoms of depression. And later it was found that these antidepressants work through the immune system, through neurogenesis, among others. Early molecules, mainly tricyclic antidepressants and monoamine oxidase inhibitors, were very effective, but created lots of problems, especially through their interaction with other diseases or with maybe with food. And this led to development of more and more molecules that target more specific neurotransmitters, maybe norepinephrine, maybe serotonin, maybe both of them, or even melatonin, and just to minimize side effects and maintain the improvement. And here we come with an ever-growing list of antidepressants. Yes, we have the older antidepressants, tricyclics and MAO inhibitors, and the newer generation of antipsychotics that keep ever growing. Despite all of this, SSRI remain the mainstay in the treatment of depression because of their safety profile and efficacy. mainly, especially for escitalopram and sertraline maybe. And we have other antidepressants, but all of these newer antidepressants that show more or less same efficacy, they have a variable side effect profile depending upon their interaction with other receptor other than serotonin or norepinephrine or those main receptors that were thought to underlie the improvement of depression. So the main problem with these is mainly GI disturbances. Sometimes we talk about the weight gain, somnolence, sexual problems. These problems that a newer generation of antidepressants try to tackle and to solve. Despite all of this, the problem did not end. Yes, we have new molecules that can treat and can save the patient many problems, but we don't have any big difference between their efficacy. More or less, they are still the same with differences in tolerability. Here, we're talking about an improvement that does not exceed the 50 or 60%, but we have 40% of patients who either partially respond or do not respond at all. Taking into consideration that the response, I need to remind you that the response takes about 2 weeks to kick in, to start. So, and we have people who do not respond at all. That's why nowadays, or even with the updates in the guidelines, we talk about different strategies to tackle this problem, either by optimizing the dose of the antidepressant, combining antidepressants, changing the antidepressants, sometimes using older generation, augmenting, combining, doing whatever, even reaching the electroconvulsive therapy and even surgery. But still, despite all of these lines of treatment, we still have something missing. The study and that was released early 21st century showed that patients undergoing all of these lines of treatment showed a decrescendo response. So we have, as you can see, even though the response rate is more or less acceptable, the remission is even much lesser. And this goes lesser and lesser as we go from one line of therapeutic line to another. So we end up, as you can see from the second line and on, with more and more people left partially treated or untreated or not functionally well. So we need a solution for this. Not to forget that the treatment of depression is not something to cure the illness, but rather to improve symptoms. And we talk about a remission and not a cure. And here in the study, as you can see here, patients who compare the response of patients who have been depressed and volunteers when they are exposed to sulpiride, which is a D2 antagonist, those who were in remission were originally depressed and in remission. Whenever they are given sulpiride, they go readily into depression, whereas it's not the case for volunteers, which means that even patients who are fine may easily remit. Their brain is not normal, but they are doing fine. And patients who discontinue the antidepressant prematurely also may relapse easily. Here comes the need for something that is rather different to treat these depressed patients, partially responsive or really resistant cases. By the way, I'm talking about resistant cases. Maybe we didn't find a proper way of treatment. That's why we call it resistant cases. But recently we're talking about, there was lots of talk about the IV ketamine, the anesthetic agent that has shown a dramatic improvement shortly after its administration. And its development led to the IV esketamine that being used in a specialized clinic as an adult treatment to oral antidepressant to improve and to maintain the improvement, to readily improve fast improvement, to maintain the improvement for those already treated and poorly responsive or partially responsive to conventional antidepressants. And this has been thought to be due to modulation of glutamatergic neurotransmission by promoting, indirectly promoting the pyramidal glutamatergic release from pyramidal neurons, as I mentioned, and mediating the response through the AMPA receptors, glutamatergic receptors, leading to a cascade of events leading to this improvement. In the same line goes the dextromethorphan testing and LSD and dimethyltryptamine that go through the same way of thinking through the modulation of glutamatergic neurotransmission. Another way of doing it through modulating a GABAergic deficit through brexanolone, which is analog of allopregnanolone. It's a neuroactive steroid that modulate or it changes the concentration of GABAergic GABA-A receptors, promoting GABAergic neurotransmission. And this one too has been approved for postpartum depression with a fast-acting onset. Within 2 to 3 days, the patient is fine. This led to the development of zuranolone. It's a per-hour treatment, also a neuroactive steroid that works through the same mechanism, but it's an oral treatment and it's undergoing the filing for FDA approval. And here we have other even more molecules, the same way of thinking, either working through the GABAergic neurotransmission or even opioid antagonist to promote dopaminergic neurotransmission and improve depression. In the same way, we talk about schizophrenia. We also schizophrenia, even though it does not affect, but mainly maybe about 1% of the population, but an equally debilitating and lifelong chronic illness that show in a number of ways. Yes, whenever we talk about schizophrenia, we talk about positive symptoms, hallucinations, everything like this. But in most cases, we have, and the patients spend most of his days suffering from negative symptoms, cognitive symptoms, affective symptoms, and the complications of treatment, mainly motor problem, somatic problems, whether it's part of the illness. Patients with schizophrenia are more prone to these problems, irrespective of what they are given. Still to be discussed, it's a matter of discussion. With all of this diversity and heterogeneity of symptoms, cannot again stem from one mechanism and cannot, of course, be treated with one medication, but rather a combination of mechanisms. So far, we try to define a few of them, maybe new response, synaptic problem, neurodevelopmental, neurotransmission. So interaction between all of them, it's still a matter of debate. So far, we still talk a lot about the dopaminergic mechanism and dopaminergic hypothesis that mainly reside on blocking or on modulating dopaminergic neurotransmission. It's been found so far a hyperstimulation of the mesolimbic pathway underlying the positive symptoms, whereas we have a hypodopaminergic stimulation of the prefrontal cortex underlying clinical and the cognitive and psychotic or affective symptoms. Logically, we need something that blocks dopaminergic neurotransmission, and here comes what the class of medication called antipsychotic, antipsychosis, anti-positive symptoms. They are meant to treat the positive symptoms, and here we are. We're treating the positive symptoms by limiting the hyperdopaminergic neurotransmission in the mesolimbic system, but they may not differentiate every pathway. So we have an inhibition of dopaminergic neurotransmission everywhere, sometimes worsening presenting symptoms, cognitive symptoms, negative symptoms, affective symptoms, and sometimes creating even new problems for the patient. Maybe I'm talking about the Parkinsonism and hyperprolactinemia. This is especially the case for first generation antipsychotics. And we know that blocking about 70%, 60 to 75% of D2 receptors is good for improving the symptoms of psychosis, whereas whenever we exceed the 80%, we have side effects. And here we have different variety of antipsychotics with different affinity to receptors, high potency, low potency, depending upon their interaction with non-dopaminergic receptors, I mean muscarinic, anticholinergic, and noradrenergic. So they give them different properties, but all in all, first generation typical antipsychotics are mainly associated with pyramidal or extrapyramidal, I mean Parkinsonism, and this may create or add the burden to the illness. Here comes the role of the second generation antipsychotics. Yes, they have a dual antagonism of D2 and H2A receptor, and serotonergic receptor, specific parts of the brain, which can give them some advantage over the first generation, that they do not decrease that much the dopaminergic neurotransmission, especially in already hypo-stimulated areas, especially the prefrontal cortex. So here we have at least less problem on a cognitive problem sometimes, and even positive effect on the mood, and less problem on motor, on the motricity of the patient. Other antipsychotics, second generation antipsychotics, even though they are growing ever and ever in as far as number, they are not devoid of problems, and they are often associated with metabolic problems, especially insulin resistance and lipid problems. This has been thought to be tackled through the generation of the partial agonists. That's to be a really very interesting idea. By blocking dopamine, certain part of the brain, and promoting it somewhere else seems to be very logical, and it fits the dopamine hypothesis associated with schizophrenia, but they did not show a superior efficacy to conventional atypical antipsychotics, but they offer a better profile as far as metabolic side effects and the list. But the problem is still there. We have patients that still partially respond, have a breakthrough psychosis. Some patients spend their life with negative symptoms, clinical problems. They are not functional. They have a substance abuse. They have more and more ever-growing medical condition. They don't have something personalized. They have a problem in adherence. They do not take the medication because it makes them feel worse. They improve their psychotic symptoms, but make them feel worse somewhere else. This has been tackled a little bit by maybe having long-acting injectables, that the list is growing, having medications given every month, every 3 months, even every 6 months, has been mentioned recently. And we have recently approved olanzapine samidorphan that tackle the weight gain associated with a very effective medication, which is olanzapine. And this combination was still very effective with less side effects. And you have the lumateperone. Lumateperone is very new. It's a very new medication that's based on the action activity of atypical antipsychotics, but still we have a role through the glutamatergic, serotonergic neurotransmission in the pipeline, an ever-growing number of medications. As you can see, they do not mostly work on D2 antagonists, but through other mechanisms. We have ulotaront that modulate and adjust and work through the adjustment of serotonergic, dopaminergic, glutamatergic neurotransmission, whereas it does not have a metabolic problem. Xanomeline, trospium, maclinide, also they work through the cholinergic neurotransmission, well tolerated, very effective against psychosis, yet they do not work through any dopaminergic neurotransmission. And pimavanserin, already on the market for the treatment of psychosis in Parkinson, it's an inverse agonist, antagonist on serotonergic receptors. It's been treated and tested for the management of negative symptoms, and the list is still growing. Thank you all for your attendance. Here I leave you with even more interesting presentation. Thank you all.
So thank you, Dr. Mazen, for a very comprehensive presentation. And we will be taking some of our the question that we received from our audience. So the first question from Marwa, she's asking you, which second generation antipsychotic would be the best choice for agitated schizophrenic patients?
Okay. There is no really a difference between the effect of second generation antipsychotic, but mostly we talk about the most effective ones. We have the olanzapine, risperidone, amisulpride, and eventually clozapine, but not the first one. So depending what the patient already has taken, how he was responsive to his conventional treatment. If he had an agitation, it was the first encounter of the patient, first episode of psychosis that comes with that's coming with agitation, or it's a relapse. This depends upon the choice of which medication to choose. So depending upon his previous response to his to previous psychotic events, and to response to his regular maintenance dose of psychotic treatment. And if it's the first episode of psychosis, I can think of olanzapine, risperidone, as I mentioned, clozapine, and amisulpride. The advantage of olanzapine and risperidone, they come also not only injectable formulation, but they also come as orally dispersible tablets. So it can be very effective whenever the IV line is not being secured. Oral dispersible medication can play a very good role and can be easily dispersed and has a very fast onset of effect to control a really agitated patient. Of course, we have other modalities, may not be enough despite all of this, and we can use a multitude of or a combination of medications for the management of a severely agitated patient. But I've answered because the question was specific on antipsychotics.
And another question, which antipsychotic has the least effect on weight?
On?
Weight.
On weight, yes. The least one, we have ziprasidone, we have lumateperone, does not have problem in weight. We have the partial agonist, especially the aripiprazole.
So those were the questions from our esteemed audience. Thank you, Dr. Mazen, again for being with us today. And we will move to our second psychiatry expert, Dr. Faris Al-Harbi, who is joining us from KSA. Dr. Al-Harbi is a consultant of psychiatry and addiction medicine and the assistant professor at the College of Medicine, King Saud bin Abdulaziz University for Health Sciences. He is the director of psychiatry residency program at King Abdulaziz Medical City, Riyadh. And beside that, he is the vice chairman of treatment and rehabilitation committee at the Drug Enforcement Administration in Ministry of Interior Affairs. He has a number of publications in psychiatry and addiction medicine that were already published. Dr. Al-Harbi will share with us tonight the recent updates in the management of major depressive disorder. Dr. Faris, we are honored to have you with us tonight as a speaker. Please start your presentation.
Assalamu alaikum. Hello, everybody. Okay, hello, everybody. Thank you for the invitation, and thank you, Dr. Mazen, for very informative presentation. Actually, we have maybe something in common with the presentation, so I will concentrate in the area that is not mentioned by Dr. Mazen. I don't know, the slide is clear?
No, we are not. You have to share your screen.
Okay.
Again. Yeah, just go on full screen mode.
Okay.
Yeah, now it's showing.
So we're talking about depression. Let's talk about the incidence of depression. If we take 2,000 patients, we will find 100 of them, they have the major depressive disorder, and 100, they have minor depressive disorders, and 200, they have subclinical symptoms. The important thing that in 50% of the patient, they may not acknowledge they have depression. Up to 50%, يعني half of the patient, they don't know that they have depression, or they didn't seek medical help. Why? A lot of patients or a lot of people, when they have depression during their aging process, they think that depression is a normal part of life, is normal part of getting old. And some people try to live with this. Other people, they don't want to take pills or take medication or going to the psychiatry. If we take like a prevalence, let's talk about Europe. In Europe, up to 322 million, they have depression. And the major depressive disorder is the leading cause of disabilities worldwide. Actually, it is second after cardiac illness that the major burden of the disease worldwide. They expecting in 2050 it will become the first burden or the first leading of disabilities worldwide. 50%, they have a chronic sick leave in Europe due to depression and anxiety. The prevalence peak of the older adulthood from 55 to 74 years of age. What about America? In US, 10% they have 1 year prevalence of depression, and 30% they have lifetime prevalence of having major depressive disorders. Around a third of the population, they may have depression during their lifetime. It's the interesting things in the studies, in the recent studies, that there is increased rate of depression in young adulthood. We know that the depression, as usual, it's more common in older people. But nowadays, with the new statistics and they found, or in the new modernization in the society, they found in America that there is an increased rate in young adults. Of course, depression is more in women than men, and more in people with lower economic status. What about Saudi Arabia? We have the recent national screening, and we found that the prevalence of depression in Saudi Arabia is around 6%. In women, it's 8.3, and men 3.1. Worldwide, that the women usually they have more depression than men. If we see the burden of the mental and physical illness, as I mentioned, that the depression is the second leading cause of disabilities. If we combine the lung and colorectal and the breast and the prostate cancer combined, we combine all of them, they have less burden than depression. So depression, على ما نقول مرض العصر. طبعا depression is associated with the huge economic cost. Like we see some studies here in Western world. I didn't find the actual studies in the Arab world, but in the Western world, the work-related economic losses is estimated, like in Canada, 6 billion per year because of depression. In UK, 8.6 billion. In Europe, 118 billion per year. In US, 83 billion. So it is a cost. This disease, it can cost a lot to economy if we didn't treat this illness. Let's go with the numbers also. 10% of those diagnosed in primary care are referred to psychiatry. What about 90%? So the people who seek help in primary health care center, only 10% they are going to the psychiatry of the people who have depression. 1 in every 1,000 patients, they are admitted to the hospital. The lifetime, this is worldwide studies, the lifetime incidence rate is approximately 33%. Also, we go with numbers. This is worldwide. It's commoner in younger people, including children. And you know, before, most of the studies before years, that, as I mentioned, that the depression is more common in older people. But nowadays, it starts to become common in young people, even in children, they have depression. So that's increased the rate of depression in younger population. This needs to be studied and addressed, even with medication, because we know that the medication in children age group is not as common as in adult. And in depression, men 1 to 2 compared to the women, and they are common, the depression in physically in people. 50% they have recurrence rate. So about half the people, they have recurrence. It's not just one episode of depression and that's it. Most of them, they have a recurrent of the illness. And 12% of this depression, of the people who have depression, they become chronically depressed. So it's become like a chronic illness. If we want to diagnose major depressive disorder according to DSM-5 criteria, it has to have 5 of the following symptoms in the last 2 weeks. So the depression is not just one day. It has to continue for at least 2 weeks or more. And the people, they have to have 5 of these. Either they have depressed mode or anhedonia or loss of pleasure, and significant change in the weight and appetite, either increased or decreased. And the sleep, either have excessive sleeping or decreased sleep amount. They have psychomotor agitation or retardation, fatigue or loss of energy. A lot of people we see in our clinic that they said with depression that, oh, I don't have energy to go. I want to go, but I can't. I stay most of the time in my bed. So that's a criteria to diagnose a depression. Feeling of worthlessness or excessive or inappropriate guilt. Also, they have a problem in thinking and concentration and in memory. And the major things that it's emergency in psychiatry. A lot of them, they are thinking about death or thinking about suicide. And a lot of patients who's suicidal, or a lot of people, they are suicidal, they are depressed. These criteria to diagnose major depressive disorder. What about persistent depressive disorder? It was called before dysthymia in DSM-4. In DSM-5, it's called persistent depressive disorder. The lifetime prevalence is 3 to 6%. In these people, they have depression, but it's less severe than the major depressive disorders. And also the time or duration of the dysthymia or persistent depressive disorder is longer. It has to have 2 of the following: poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration, and feeling of hopelessness. If you notice that some of the criteria in persistent depressive disorder, it is similar to major depressive disorder, but it is less severe. It's need only 2 of them. And they don't have usually suicide or death wishes, the people with dysthymia or persistent depressive disorder. The course of major depressive disorder, according to the study, the mean age of the onset of MDD is 29 years old. And the mean of the people who have depression, they have 3.85 episodes in their lifetime. So the most of the people with depression, they have multiple episodes, not only one episode of depression. Median duration of the longest or the only episodes is 26 weeks. So it is usually the depression is long episode. In USA, they said that in USA studies, I wrote it down, 1 in 3 people with lifetime major depressive disorder, they have no treatment. يعني الثلث ما يأخذون أي علاج رغم أنهم يعانون من الدبريشن في أمريكا. What about our society, Arab society? I think that more than that in Arab society, most of the people with depression in our society, that's my assumption, but I don't have study, but most of people in our society, in Arab society, they don't go to psychiatry or they don't receive treatment, because the depression in our society usually linked to weak will or ضعف iman, or this is a part of the life, you have to tolerate it, don't go to psychiatry, you are not crazy. So most of the people, I think in our society, they don't receive medication, although that they are suffering of depressive disorder. It's need a study to confirm this assumption. Why important to study depression? As I mentioned, major depressive disorder is a common cause of disabilities, and they have recurrence. It's not just only one episode, and highly comorbid with other medical problems. Now we go to the emergency. So the emergency of or the emergency status of depression is suicide. So suicide rate in the US have risen by 30% from 2000 to 2016. So the rate of suicide is increasing. Age adjusted in suicide rate in 2017 is 14 لكل 100,000. It's second leading cause of death في الage group من 10 to 34 years old, and it's the fourth leading cause of death in 35 to 54 years of old. So it is serious. It is not something simple. 2/3 of those who die by suicide have depression at the time of the act. يعني ثلثين اللي حاولوا انتحار أو ماتوا بالانتحار كانوا مكتئبين. When you have patient of depression, you have to rule out mania or hypomania, because sometimes you have a mixed episode of mania or agitated mania or depressive mania. So the symptoms appear to you as a clinician as agitated depression while it is mania or hypomania. Why it's important? Because if your patient has a mania or hypomanic symptoms and you give him antidepressant, you make things worse. There is, of course, there is a lot of formal assessment of bipolar mania. I just give an example. So what about treatment of depression? Usually beginning of treatment of depression in adult, usually we start with antidepressant. We choose SSRI and SNRIs because older antidepressants like tricyclic, MAO inhibitors, etc., it has a lot of side effects. So nowadays, most of the guidelines recommend to start SSRIs or SNRIs. Of course, we shouldn't forget the role of psychotherapy. A lot of us as psychiatrists, we forget psychotherapy. We concentrate only on medication, while the psychotherapy, it can be so effective. And for mild and moderate depression, the effectiveness of psychotherapy almost equal to antidepressant. While in severe depression, okay, of course, the medication is more effective than psychotherapy. But we shouldn't forget the role of psychotherapy in the treatment. Of course, the best recommendation is to combine the antidepressant with psychotherapy. And the most common form of psychotherapy used nowadays is CBT. When we try to select the medication, we have a lot of medication. As I mentioned, SSRI, SNRIs, it's more than 10 medications. So as a clinician, how we choose that antidepressant? Usually, we should look to many factors in choosing antidepressant. First, what is the target symptoms? What is the specific symptoms you are target? So, like I give you an example. If your patient has main problem in sleeping, he cannot sleep, he has insomnia, I may choose mirtazapine because mirtazapine has more effective in sleep than other medication. If our patient concerned about weight, like the question that has been asked to Dr. Mazen about antipsychotic, What about antidepressant? If the person is concerned about his weight, of course, I will not choose mirtazapine. I may choose fluoxetine or others. So let's go to the specific depressive symptoms that it's target. Second thing, comorbid conditions. If you want to give medication and the patient has a lot of medication, you will choose the medication that has the least drug-drug interaction. Like I may choose escitalopram or Cipram. The other factor is safety. If your patient has suicidal ideas, you would not give him tricyclic, because the tricyclic high dose, maybe double or triple dose, it can be lethal. So I will not choose tricyclic if my patient has suicidal ideas. So we have to consider safety in choosing the medication. Of course, as I mentioned, side effect profile. If it is important, we see the side effect of each medication so it will not interfere with the patient. We have to discuss the choices of medication with our patient. Concurrent medication, as I mentioned, interaction, ease to use. Like some medications can be taken 2 or 3 times a day, while other medications can take only once. It's easier, especially if the patient needs help, like if the patient is schizophrenic and he needs antidepressant with schizophrenia, and the family usually, or the mother or father, give the medication, it's easier for them to give him once a day instead of twice. A medication need to be taken twice a day. Patient preference and expectation has to be considered. Cost. If you have patient has a low budget, you may choose tricyclic. If he has high budget, maybe you choose a newer medication. Previous response to antidepressant. If you have patient taking medication, they have a very good response, and you stop medication, they have a relapse. So I may choose that medication. Family, yes. If you have one of family member improved in one of the medication of antidepressant, please try the same medication with his first-degree relative. According to the study, he most likely will improve to the same medication. We have to give our patient, we discuss with our patient about the antidepressant, we give him full information. Like this information is very important. The side effects often precede therapeutic benefit. Your patient came to you, and you give him like some medication like SSRI, and he may start to have GI symptoms, headache, etc. And then he came to you and he said, "Doctor, your medication is not helpful." So we have to explain to him from the beginning, you may have a side effect, and usually the side effect came before therapeutic benefit of that medication. The side effect usually subsides with the time. Like if we're talking about SSRI, the first 2-3 weeks, you may have GI symptoms, headache, etc., and most likely it will subside with the time. And this is an important point. Some people, we have to discuss with our patient that we need the medication for a long time. Even after the patient improved, you have to continue on medication. So that has to be discussed with the patient at the beginning, because the main reason for relapses is stopping medication. And a lot of people, they stop medication because we forget as a clinician to discuss the course of the treatment. So patient, even after improved, he has to continue the medication for a while, usually 6 to 12 months after improving. Although you may start feeling better in as little as 2 weeks, it takes more time for full response and remission. Take the medication as prescribed even after you feel better. So not just after you feel better, you stop the medication. Don't stop taking medication without calling your clinician. Usually we have to discuss that with our patient. If you have an idea to stop medication, please discuss that with us before you take decision. But what about the problem in major depressive disorder? That's the problem we have with the treatment of major depressive disorder. that 30% they don't respond to the traditional antidepressant. Not all patients respond to the medication or the traditional medication. The second problem that usually we need time to achieve response. And the people, they are in a hurry. Doctor, I take medication for 2 weeks, there's no change. So we have to discuss, usually medication take 3 to 8 weeks to improve. The third problem that we face it as a clinician, that the patient is the best response in the first trial. With the second or third or fourth trial, their rate of remission is decreased, as Dr. Mazen mentioned in his slide. So if we want to discuss the treatment-resistant depression, if we want to try to define what is the treatment-resistant depression, it is poor unsatisfactory response after 2 trials of antidepressant. So if the patient has the depression and you try the first trial and he's not improved, and you try a second trial of the medication and he's not improved, you can define him now as a treatment-resistant depression. With the treatment-resistant depression, it's increased morbidity, mortality, higher healthcare costs, more severe and functional impairment. It is more severe type of depression. It is 10 to 30% of our patients, maybe they have treatment-resistant depression. So the consequences of treatment-resistant depression, usually they have more comorbidity. The rate of hospitalization increased by double, 36% longer hospital stay, and 7-fold increase in the rate of suicide. يزيد نسبة الانتحار 7 مرات في المريض اللي عنده اكتئاب مقاوم للدواء. As mentioned Dr. Mazen, in the first trial, usually the patient up to 37% they improved. In the second trial, 31%. In the third and fourth trial, the response is decreased significantly. In that area, we call treatment-resistant population or treatment-resistant depressive patient. As I mentioned, with the more trial of medication, the less patient get remission. So if you have treatment-resistant depression, what you will do as a clinician? Usually we can do many strategies like augmentation. We add a second medication. We can add augment also with lithium or thyroid, or sometimes we augment with antipsychotic. Also, we can add some kind of stimulant like methylphenidate and Adderall or Concerta, etc. Optimize, combine, switch classes of antidepressant. Usually we start with optimizing. If the patient didn't respond, we increase the dose for enough time and enough duration. If he shows some kind of response, we augment the medication. If he has no response, we can switch to other classes. Then if we try two trials, then we can, and the patient not responding, we can classify him as resistant depression. As I mentioned, we shouldn't forget the role of psychotherapy. Also from therapeutic option, ECT, electroconvulsive therapy, العلاج بالصدمات الكهربائية, which may consider by a lot of authors is the best therapeutic option for treatment-resistant depression. Also repetitive transcranial magnetic stimulation, although the studies is not, it's acceptable, but it's not as strong as ECT. Option for treatment-resistant depression, that ketamine and esketamine and started to be in the market. And usually we start ketamine and esketamine after 2 trials of patient not response. And psilocybin, it's a new medication still under studies, but it show a lot of studies show it's a promising effect. If we can see here, first we try the first trial of antidepressant. If we want to take like algorithm, our guideline for treatment, patient came to you and he has depression. What you will do for him? you start first antidepressant medication, usually SSRI or SNRI. Patient didn't respond, please try another medication. It's preferred to be in the different group. Like if you start with SSRI, try SNRI or opposite. Patient tried 2 trials and he didn't improve also. Here you can start with strategy. You can define them now, treatment-resistant depression, and you can start either switch to another medication, augment, combine, or use esketamine. If the patient with all these still not responding, please go to ECT. ECT هذا العلاج القديم الفعال. ECT it has been used, I think, since 50s, and it's very effective medication, although it's not used as supposed to be. يمكن الناس خايفين من علاج بالكهرباء، يمكن الإعلام سابقا كان يتكلم عن كثير علاج الكهرباء بالصورة سلبية. But it is very safe. It's safer than medication sometimes. And the response rate with treatment-resistant depression is 70%. يعني البيشنت اللي صار ما يستجيب للأدوية 70% إنه بعد الإي سي تي إنه يتحسن. في الميجر ديبريسيف عفوا 70% في الميجر ديبريسيف as a whole في treatment resistant is 58%. It's indicated when if the patient has depression with psychotic feature or he has severe depression with catatonia or treatment resistant depression or elderly patient who cannot tolerate or take antidepressant or pregnant lady. If you have a pregnant lady, you don't want to give her antidepressant because you are afraid of side effect, please give her ECT. The common risk or common side effect is confusion, headache, nausea, fatigue, and usually this side effect is temporary. It's resolved with time. And retrograde amnesia. كثير من المرضى أكثر شيء يقول يزعجهم retrograde amnesia, but it usually is temporary. It's resolved with time. So if you have resources for further reading, these some resources. Thank you.
So thank you, Dr. Faris, for a very enriching presentation. And please allow me to take just a few questions, although believe me, we have a lot of questions for you. But not to delay Dr. Mahdi, we will take only a few ones. So the first question, what patients are candidate for admission, for hospital admissions?
This is a very good question. When we choose the patient to be admitted.
Yes.
Yes. If the patient, the first thing, if the patient has a risk for his life, if he has suicidal plan or suicidal attempt, or you're afraid that the patient may kill himself. If the patient became psychotic and he started to be dangerous to himself or to others. If the patient, he lose his ability to judge, يعني أهليته أو and he cannot decide for himself, like he's became extremely psychotic, refuse the medication, he has to be admitted. Also, if the patient has a major depressive disorders and he choose to be admitted, this is the main reason for admission, or the patient need ECT.
A second question, what about patient taking anti-arrhythmic medication? So do we have any interaction with antidepressant, and how we should monitor those patients?
Can you repeat the question, please?
So patients who are taking anti-arrhythmic drug for arrhythmias, are those patients contraindicated to take antidepressant, and should we monitor them more carefully?
So the question that the patient taking antiarrhythmic medication, shall we give him antidepressant or not?
Yeah.
Actually, that's depend on drug-drug interaction. If you want to see the patient with arrhythmia, it's better to give him ECT, actually, in general speaking. But if you want to give him antidepressant, you have to look for a profile for each antidepressant. We see what is the safest, because with each medical illness, there is some antidepressant safer than others.
Yeah.
So like you don't give him tricyclic, of course, but you can choose some medication is less cardio.
Yeah. citalopram, for example, causes
Yes.
QT prolongation. We don't
Yes.
like it in patients with arrhythmia, so we go for the drugs with the least effect on the heart.
Yes.
So another question: some antidepressants cause or they exacerbate anxiety by themselves. What do we do in this situation?
This is a very interesting point. We know that the antidepressant, especially the SSRI, in the first 2 to 4 weeks, it can increase anxiety by itself. Then it can decrease the anxiety. It is temporary issues. So if you start antidepressant, يعني إذا بدأت SSRI أول أسبوعين إلى 4 أسابيع, anxiety it can be increased. So what shall you do? So when you start an anxiolytic or antidepressant or for anxiety, please don't use it alone at the beginning. Give him something to calm your patient. So you can start with like fluoxetine or paroxetine with benzodiazepine, like small dose of alprazolam or clonazepam. Or if you don't want to chew for a while, for like 2 to 3 weeks, then you can take out the benzodiazepine or sedative and continue with antidepressant. And if you don't want to take benzodiazepine, you can choose a small dose of antipsychotic like Seroquel if the patient is not able to sleep, or Celebride, or sometimes we use small dose of mirtazapine with SSRIs. So don't give SSRI alone for your patient if he is drug naive. If he is drug naive and he has high anxiety, don't give SSRI alone. Give him some medication to calm him down, especially in the first 2 to 4 weeks. After that, you can take it out.
Thank you, Dr. Faris. We have more questions, but we will answer them offline as as I mentioned, we don't want to delay Dr. Mahdi. So thank you. It was an honor to have you. Our third lecture discussing the latest treatment for schizophrenia will be delivered by Dr. Mahdi Al-Anzi. Dr. Mahdi is a consultant psychiatrist, head of Department of Psychiatry in Al-Amal Complex for Mental Health in Riyadh and the manager of Sabiq Mental Health Hospital. He achieved the first place at kingdom level for performing ADAA improvement project at the Ministry of Health in 2017. He is a trainer and supervisor of the Saudi Fellowship Program of Doctors for Mental Health. He was the head of department of the emergency section in Rida Mental Health Complex. Thank you, Dr. Mahdi, for accepting our invitation to be our speaker tonight. The floor is yours. You can start your presentation.
Okay, thank you. It's my pleasure to be here with you. And I would welcome my audience and my colleague and thanking the organizing committee to give me the opportunity to focus on very important subject. It is the use of long-acting injectable antipsychotic in schizophrenia. So we know that in our specialty, we all agree that there is a lot of underutilized for this optional treatment because a lot of reasons, maybe we'll talk about it in brief now. So basically schizophrenia, it is a mental disorder characterized by disturbance, last for 6 months or longer, including at least 1 month of delusion, hallucination, disorganized speech, grossly disorganized, or catatonic behavior or negative symptoms. First time they talk about schizophrenia as illness, it was in 1797. That time they coined the term dementia precox, which means premature dementia. And the first person was coined this schizophrenia term. It was Paul Plural. It was in 1857. We have a lot of challenges with the schizophrenia. The first important one, it is the adherence. All we know that the schizophrenic patient, always they are not adherent to the medication, and a lot of study talking about that. The second, obstacle, cognitive dysfunction. also we know that there is deterioration in cognitive function with a schizophrenic patient, and that's make a lot of burden in the patient and his family. Also negative symptoms in form of lack of interest and apathy, and with catatonic symptoms sometimes. Also, we have residual positive symptoms. We know that whatever we have antipsychotic medication, always there is some resistant cases with residual positive symptoms. And finally, we have also a problem of side effect. We know each medication has its own side effect. Why we always underutilized using the depot injection or long injectable antipsychotic? There is a study here showed that most of psychiatrists here, the most reason, or maybe the first important reason that we should change it later, that 86 of psychiatrists, they think and that there is sufficient adherence to the oral. And 86 of psychiatrists, they thought that the patient will adhere to the treatment, and 80% of psychiatrists, they think the patient will refuse this optional treatment. 75% they thought that the antipsychotic is not available as long-acting. 71% they talk about the cost of a drug is very expensive. They don't know, sometimes they don't calculate the hospitalization and the burden and all these costs. And 68, they will think that not appropriate option after relapse. 58%, they think poor controller of effect compared to the oral drug. And 31, they talk about high ABS risk with long-acting injectable antipsychotic. This study showed that there is always poor adherence during the treatment. It's the major risk factor for relapses in schizophrenia. And only 37.3% of patients adherent to the treatment in the first 6 months. Even with partially adherent patients, they showed that percentage of patients with schizophrenia were rehospitalized by maximum gap in days during the treatment. We noticed here in this diagram, if we have a gap between treatment from 1 to 10 days, the percentage of rehospitalization was 10, increased to 20%, when the period from 11 to 30 days, and reach 25% when would be 30 days and more. So interruption in the treatment is a major risk factor for relapses and rehospitalization, and patients may become harder to treat over time as recurring relapses lead to reduced treatment response and increased treatment resistance. And this study shows that the choice, timing, and the duration of the treatment, symptoms control, and protecting patients from impact of schizophrenia. Deteriorating course, brain tissue loss, and treatment resistant with repetitive relapses after the first episode in schizophrenia. Here we know the level of the function, as shown here in this diagram, is deteriorating gradually with first episode, second episode, third episode, fourth episode. And even there is obvious degenerative changes in the brain according to the relapses. The more relapses, the more degenerative changes in the brain, and the more chronic relapsing and the residual symptoms and treatment resistant. So in this study showed that each relapse associated with increasing residual symptoms severity. We know with the first episode, the percentage of psychotic symptoms, the persistent psychotic symptoms would be 12%, 8% with the second episode, increasing to 19% with the third episode, and 27% with the fourth episode. So in addition to the increased residual symptom severity, there is some evidence suggests that a higher dose of antipsychotic medication sometimes is required to treat a relapse following discontinuation in the first episode psychosis. So proposing long-acting injectable antipsychotic early routinely could give patient the possibility of a future in which they can look forward to achieving their goals. And this would be suggested by APA guidelines, which suggest that the patient receive treatment with long-acting injectable antipsychotic medication if they prefer such a treatment or they have history of poor or uncertain adherence. Actually, I will talk in this quick time with the major two or the commonly used now, paliperidone palmitate injection and Abilify Maintena. Also, there is common medication that are available like haloperidol decanoate, paliperidone, palmitate and Sustaina, and trifecta, and in the future would be Invega Averia, and risperidone, risperidal consta, flunofenazine decanoate, and aripiprazole, which is Abilify Maintena. Here, we'll talk about Invega Sustaina. It is a pre-filled syringe of paliperidone palmitate, is an aqueous suspension for IM administration, monthly injected with possibility to shift to 3 monthly injection after. No need for oral supplementation, variable doses for available concentration to match different patient profiles. In this study, Invega Sustaina offers optimal efficacy. This was a post-hoc analysis from single-arm, multi-center open-label 6-month interventional study in non-acute but symptomatic patient with schizophrenia. Patients were switched to Invega Sustaina after previous unsuccessful treatment with oral antipsychotic. We noticed here in this diagram that recently diagnosed, as when you offer the treatment early, there was comparison between the recently diagnosed and the chronic patient. 71 would be of patient will decrease in PANSS total score versus 59 to the chronic one, with the reduction in more than equal 20% decrease, and 39.4 for recently diagnosed versus 24 for more than 50% decrease in PANSS score. That's mean when I offer the option of this Sustaina early, the more benefit I get from decrease in the PANSS score, total score. Okay, I'll try here, I'll talk about PROSPAL trial, which is the objective of this study to evaluate the time to relapse, relapse rate, and other clinically relevant outcomes. Patient recently diagnosed from 1 to 5 years with schizophrenia DSM-4 treated with paliperidone palmitate and a typical long-acting versus the investigator choice, which is of 1 of 6 more frequently prescribed oral antipsychotic like aripiprazole, olanzapine, quetiapine, paliperidone, risperidone, or haloperidol over 24 months. And this one, it's clearly showed that sustained efficacy versus the orals. The 85 percentile for the time to relapse, it was 469 days relapse free with Invega Sustaina versus 249 days with daily orals, which almost doubled the time. Here we talk about paliperidone 3 months. It is a palmitate ester of paliperidone, which can be administered once every 3 months, and the same active substance as 1 monthly paliperidone in Invega Sustaina, using the same technology, but in different concentration and with different particle size, thereby allowing administration once every 3 months, and is intended to be used in the patient who been adequately treated with monthly paliperidone palmitate for at least 4 months. Here, this study showed that the trifecta maintained the improvement in patient functioning achieved with Invega Sustainer. In this active comparator study, patient was treated with Invega Sustainer during the open label phase, experienced an increased mean total personal and social performance scale of 11.5 points. So trifecta also maintained this improvement in patient functioning, further even increase with a slight over the Sustainer by 1.3. So in this study, Kim et al., time to schizophrenia relapse and relapse prevention study of antipsychotic developed for administration daily, once monthly, and once every 3 months. It was a post hoc analysis in order to evaluate the differential risk of relapse after discontinuation of paliperidone in its different forms, oral paliperidone 1 month oral and 3 months. This post hoc analysis compared time to first relapse of schizophrenia symptoms in subject assigned to placebo between relapse prevention study of oral paliperidone oral and 1 month and 3 months. Here, it's clearly obvious that the longer the half-life, the longer the patient are protected from relapse. We noticed with the oral that the duration was the 50% of patient was free of relapse till 58 days, comparison to Invega Sustainer 172 days up to 200 days, and finally compared with trifecta, which was 395 days, almost doubled the time, or doubled and a half for comparing Sustainer and trifecta. So trifecta provides the longest protection compared with other formulation when patients stop the medication. The side effect profile of the trifecta, safety and tolerability profile of trifecta is consistent with that of other paliperidone formulation, was not associated with any new or unexpected adverse events. The majority of adverse events were mild to moderate and didn't result in treatment discontinuation in clinical trials. And similar changes in the body weight were observed with trifecta and Sustainer, means increased in the body weight over 15 months was lower with trifecta 2.2 versus 3 kilogram for Sustainer. About injection site reactions and injection site pain were mild with the trifecta regardless of injection site and failure. And finally, trifecta exhibited a low rate of potentially prolactin-related adverse events in the clinical trials. Here's summary for the paliperidone 3-month plan. Usually we can start with the previous oral paliperidone or risperidone, and then we can start with loading initiation dose with 150 milligram Invega Sustainer, and with after 8 days we can give another dose of 100 milligram, and we can adjust the dose according to the clinical response till reach the maintenance dosing. And before we go to the trifecta, at least we should have 3 maintenance doses. That's mean 3 months before we can start to trifecta. So after that, we can start trifecta and according to the previous dose of Sustainer. And here this schedule, it's between converting the doses from Sustainer to the trifecta. 50 milligram with Sustaina would be equal to 175 trifecta. 75 will be 263. 100 milligram would be 350. 150 it would be 525. The dose always of trifecta should be based on the previous paliperidone 1 month dose using 3-point-fold higher dose, sometimes multiplied by 3.5. So with paliperidone starting from the oral till we reach the trifecta, we can achieve symptom control, help your patient with schizophrenia achieve their functional goals by offering effective symptom control till reach long-term relapse prevention with Sustaina, give your patient with schizophrenia opportunity for a future in which they can be confident in their treatment till we have reached the patient well-being improvement with trifecta, offering your patient with schizophrenia and the possibility of a future and remission. In summary, trifecta offers the unique freedom of only 4 administration per year, and this will help the less burden for the patient and for the family, because we know that always there is resistance from patient to take frequent injection or frequent oral doses each day. Provides enduring protection from the risk of relapse, generally well tolerated and with tolerability profile as similar as that for Sustaina. Time saved with trifecta can be used to focus on other aspects of patient lives and treatment. Here we can go to the Abilify Maintainer in this study. This relapse study was investigating the cluster randomized trial. Where? Okay. Sorry, there is some. Okay. The relapse study this study is investigator-sponsored, initiated multi-center cluster randomized controlled clinical trial with follow-up duration of 2 years. The objective was to document the acceptability of treatment with long-acting antipsychotic medication to early phase schizophrenic patient. All sites were community real-world mental health clinics, and efficacy assessment as at baseline was 12 and 24 months, safety assist at baseline 6 and 12 and 18 and 24 months. The clinician choice was oral antipsychotic, including but not limited to the aripiprazole, risperidone, lorazepam, quetiapine, olanzapine, ziprasidone. As we noticed here, that time remaining without having first hospitalization under this proportional hazards assumption, the hazards ratio for time to relapse hospitalization was 0.56, favoring the Abilify Maintainer 400, comparing to the control, the clinician choices. The mean survival time until first hospitalization was 613 days for Abilify Maintainer, comparing to 530 days for clinician choice. So in conclusion, the relapse study, it is the largest study evaluating effectiveness of Abilify Maintainer 400 versus clinician choices in the early phase of patient. Relapse study demonstrate with the proper training, practitioners are able to communicate and potential advantage of long-acting injectable antipsychotic even in early stages and engaging patient through motivational interviewing, shared decision-making, resulting in high acceptance rate of 86. So it's important that this be implemented across as many clinicians are possible. And there was 91% of patients on Abilify Maintainer participants received an injection in the first 3 months of the study. Abilify Maintainer can significantly delay time to first stabilization, a personally and economically important outcome. Under the proportional hazard assumption, the hazard ratio for time for stabilization was 0.56, which favoring the Abilify Maintainer versus the clinician choice. Clinician should be broadly considered long-acting treatment for patients with early phase illness. Also, this last study for aripiprazole once monthly, Aspire study, it was a study to show that mean PANSS total score over the course of a treatment. We start with the oral aripiprazole first, then and with the oral stabilization phase on aripiprazole, then stabilization phase on aripiprazole once monthly was started from 12 weeks to 36. And after that, we have 2 arms. A group started and continued with aripiprazole once monthly, and a group double-blind, placebo-controlled, randomized with the drawer phase started with the placebo IMD. And we noticed that the group with that Abilify Maintainer, they maintained the same reduction in the PANSS score, while group with the depot injection placebo, they relapsed. So the last message I want everybody to take to home, that in this study, they showed that initiation, the atypical long-acting, within the 5 years of onset of the illness was compared to those in more than 5. They showed more longer time due to discontinuation, greater improvement in PANSS scores, longer time to relapse, higher remission rates, and finally, greater improvement in brief-active briefing scores. And thank you for your listening and having you with this slide.
Thank you, Dr. Mahdi, for an excellent presentation. So let us take some questions quickly. I know you are late and you want to go to start your clinic. So the first question, psychotherapy for schizophrenia patient, does it help in combination with pharmacological treatment?
Yeah, as we know, there is old belief before that the psychotherapy is not benefit with psychotic patients, but recently all the studies showed that there is benefit, but we need some experts to focus on this field and this domain. And I think if we included the caregiver in this domain, I think education of the family and patient, and especially now the trend for the improving the quality of life. So I think there is always nice space to have psychotherapy, but under the well-trained and experts one to improve this domain. Yeah. Yeah,
of course. Another question from Sarah. She's asking about the acceptable overlapping period time between one dose of paliperidone palmitate and a second dose of these long-acting injectable antipsychotic. So if a dose, the question is if a dose is missed, and or if the second dose were missed for longer time, what is the strategy for restarting again those long-acting injectable?
With Sustainer or trifecta?
Trifecta.
Because the good point with the Sustainer and trifecta, always there is some period flexible. I think with Sustainer, if the time where one week and around, they can start. There is no problem that we can continue in the same dose. And the duration will be 2 weeks with the trifecta. So if it is with this one, I think we can start. We can continue the same dose.
Another question on anticholinergic medication, benzotropine, benzaxol, those medications are difficult to get, and sometimes they are out of stock, are not available, and they are not, the patients cannot have access to those type of drugs. So do we have any alternative?
Okay, usually our practice, sometimes just we start with antipsychotic without any anticholinergic, because ABS, it's not that very common with the patient. There is some percentage of patients will have it. So even, especially when we have the patient in the inpatient and admitted, usually we start without any anticholinergic, especially some molecule which we know that is not prone to the extrapyramidal symptoms. Once we have this side effect, we can over the anticholinergic after that. So yeah, we know this problem, especially when we have it in the private sector, that there is some limitation in that. But we can start and see if the patient develop this side effect. If we have the anticholinergic, we will start for a while. Then after that, sometimes they disappear and we can discontinue the anticholinergic, or shifting sometimes to the molecule that less side effect, less ABS side effect.
A final question: can we use olanzapine in agitated child, and what is the dose?
I don't hear you, doctor.
Can we use olanzapine in agitated child, and what is the dose?
In child?
Yeah, olanzapine in an agitated child.
This information I can't answer about it. Yeah, I'm not sure about it.
Okay. Thank you, Dr. Mahdi, again for being with us. I will move to Professor Muhammad Al-Mukhawi, our last speaker for tonight, also joining us from KSA. He will teach us on how to increase the effectiveness of therapies in patients suffering from schizophrenia. Dr. or Professor Al-Mukhawi is the Executive Director of Medical and Clinical Affairs and the Head of Addiction Department at Irada Complex for Mental Health Hospital, Dammam, Saudi Arabia. He is a LEAP certified trainer, which is a set of techniques in dealing with psychotic patients. He's a certified trainer also of the General Organization for Technical and Vocational Training in Saudi Arabia. In addition to that, he is a certified educator guide for adolescents. Welcome, Professor Al-Mukhawi, for our educational activity tonight. It is our honor to have you with us. Please start your presentation.
Hello, good evening, everyone. It's my pleasure to be with you, and thank you for your invitation and the organizer for this good event. Unfortunately, I came at the end of the session with the brilliant speaker. Actually, I don't think there is much to add, but I hope you will find good information that will help you and will help us in our practice. My colleague mentioned most of this information, but I will focus on other points they didn't mention. Let me okay. As my colleague mentioned about schizophrenia, which is considered as a chronic severe mental disorder that affects person thinking, act, express emotion, perceived reality, and related to other. Also, it's the incidence of schizophrenia is 1% of population, and it's considered as most disabling and economical catastrophe disorder. It's got a lot from our economy and even on the patient and his relative, because usually schizophrenic patients, this disorder not affect only their mental health, that also affect their physical health, because part of this disorder which affect their cognitive function, they will neglect themselves, disorganized, they will not take care about their health, so they are more prone to have other clinical, other physical problem like diabetes, hypertension, which is cost a lot on the, which is considered as a burden on the patient and their family. Also, it's associated with impairment in social and occupational function. According to the WHO, it's considered as the top of 10 cause of years loss of disability worldwide for both men and women. This is the core symptom. My colleague mentioned most of them about positive symptom, negative symptom, cognitive symptom, in addition to mood symptom, and also the effect of their social life. And this is Dr. Mahdi. He mentioned about this slide, the course of schizophrenia, which starts with pre-morbid. Usually in this step or in this stage, there is no clear symptom of schizophrenia. Usually they have, sometimes they have just negative symptom. After that, they move to prodromal symptom, which the negative symptoms become more clear. Some of them, they have odd behavior and odd thought and some bizarre behavior. Then they start with acute phase, which called here a progressive phase. And this stage, it's very clear they will have most of the patients, they will have positive symptom, delusion, hallucination, disorganized behavior, disorganized speech. Some of them, they will continue to have negative symptom, and some of them also, in addition to that, they have negative symptom. Then they will move to some of them last step, which called residual symptom. Usually the positive symptom subside at this stage and just continue with negative symptom and cognitive dysfunction. The important point in this slide, on this point, as early as we start treatment, the patient's condition will be, and the improvement will be better than if we start the treatment later on. The scope of management of schizophrenia, the goal treatment of schizophrenia was in the past was to control just the positive symptom only. Usually they were focused on how to improve this positive symptom, delusion, hallucination, aggressive violence. But recent goal changed, which to focus on minimize symptom and functional impairment, not only just to subside a positive symptom, but also to improve their function, minimize side effects of pharmacotherapy. For that, there is rapid change in our medication, there is improvement in medication, the new generation of medication, they are more effective with less side effect. In addition to that, avoid relapse, which consider actually, especially for the family or for people who take care of that patient, they were afraid of relapse, because usually relapse associated with admission, and it takes a long time for improvement. And management of schizophrenia, as we mentioned, most of the medication or most of the antipsychotic, either antipsychotic pills or long-acting, is effective for positive symptom, but not proven and have little effect on negative symptom or cognitive dysfunction. Sometimes we need to combine antipsychotic or adding adjusting agent to antipsychotic, have also yield disappointing results. For example, in my clinic, for me, it's very easy to control or to improve improve positive symptom for the patient, and you see a good result with time. But unfortunately, with negative symptom, it's considered like disappointing, either to the physician or to their family, because it takes long time and very little of the patient they have improvement in that negative symptom. The challenge in treatment schizophrenia, which is lack of efficacy, medication, and adherence, which is considered the most challenges we are facing. How to keep this patient adherent to their medication, especially when they feel better. When they feel better and they feel they become excited, they start to ask, when, at what time, when can I stop my medication? Not only the patient, also their family. Usually they ask this question: what time we have to stop medication? We see that our patient feel good. Why we have to continue on this medication? We just see the adverse effect and and the previous symptom subside. So usually the dialogue is happen after improvement. Also, negative and cognitive dysfunction not improved by current pharmacological treatment. Also, tolerability problems. Actually, as we know, the patient tolerance to the treatment is different. As Dr. Mahdi said, some patients we can start them with antipsychotic without anticholinergic, and they will not suffer from extrapyramidal side effect. On the other hand, we have another patient, they will suffer from ABS either with a very low dose of antipsychotic that make them not adherent to the medication. So how to deal with this problem is a challenge. Actually, in psychiatric treatment in general and schizophrenia, we are not focused only on pharmacological intervention or antipsychotic. We need to maintain we need to maintain treatment of the patient recover from an acute and psychotic episode of schizophrenia. Comprehensive program provided plan include pharmacotherapy, case management, family intervention, also community outreach service. Because sometimes focus on antipsychotic will improve little symptom, but some symptoms, especially cognitive dysfunction and negative symptom, they need another intervention, and like psychotherapy, especially if we have a good, well-trained psychologist. The multidisciplinary intervention has been associated with less readmission rate and low core illness symptom, in addition to improvement interpersonal and everyday living skill. Actually, our aims, our goal with patients who have schizophrenia, not only subside the symptom, we are looking to improve their quality of life, how he will take care of himself, return to his work if he's a worker, return to his continue his study if he's a student. This is our aim and main concern, because medication, most of our medication will control the symptom, especially positive symptom, but we are looking for improve their quality of life and how to they return to the life and live with like other people. Regarding patient education, sometimes we think patient who has schizophrenia, we don't need to expend a lot of time to educate them, because we know they have some cognitive dysfunction. So some practitioner, they focus on family and they educate the family about the disorder and about how to use medication and side effects, and they neglect or they not focus on the patient about because of this reason, which is cognitive dysfunction, which is wrong. Actually, a lot of patients who have schizophrenia, they will take care of their medication and they will be adhered to their medication if we spend a good time with them to educate them about their illness, about the side effect of the medication, about risk of recurrent symptom if they stop their medication, and also educate them how to use this medication, educate them about side effects, because sometimes some patients, they think this side effect means they are not benefit from this treatment, or that mean this treatment is harmful for them. But if we educate them about the side effect and we consider that maybe you will have so and so of side effect, they will be ready to deal with that side effect and consider, and especially if we tell them sometimes the side effect, it means this medication is working good with you. So this education is very good for the patient and will help us, will help them to be more adherent to their treatment. Regarding follow-up monitoring should include symptom assessment, review of medication and side effects. So every visit for the patient, we have to ask them about their symptoms. If the patient in last visit he told me about some delusion or hallucination, I have to ask him how he about that symptom. Is it still increased? Is it decreased? Also, we ask them about their medication, how their if the patient is adhere to his medication, is there any side effects? Also, in addition to that, we have to monitor, we have to do periodic laboratory tests, because we, as you know, antipsychotic, with antipsychotic, there is a possible for metabolic effect. So we have to monitor this, and we with frequent checkup. Their most recommendation for first 3 months, we have to do this monitor every 1 to 2 weeks for first 3 months. Then we can do it every 3 or 6 months. Regarding non-adherence, which consider the main problem with our patient. Actually, not with psychiatric patient, it's considered a big problem with all disorder. Medication adherence is a major problem in all area of medicine, either on psychiatric patient or non-psychiatric. WHO mentioned poor medication adherence for chronic disease is a worldwide problem. Rate of adherence about 50% in developed countries and lower in developed countries. Non-adherence lead to poor adherence to oral antipsychotic. That is the most common cause of relapse. How we assess the adherence? Actually, there is many ways to assess the adherence, not only with self-report, but also we need to use objective tools as medication adherence rating scale that can be used with patients who have schizophrenia, pill counts of I prescribe for the patient 30 pills for 1 month, and give him an appointment after 1 month. I have to ask him if he told me, oh, still I have 10 pills or 15. That means he didn't take his medication for a few days, for 10 days, for example. Also, we assess the adherence by informant who's living with him at home, his mother, his wife. They can help us to assess the adherence with the medication. And during assess the adherence for the medication, And instead of asking direct question like, are you taking your medication every day? Maybe the easiest answer will be, yes, I take medication every day. But there is another way we can ask our patient about their adherence. For example, we can ask him, do you think you benefit from your taking your medication? Have you ever decided not to take your medication on a purpose? Or when do you usually take your medication? This to assess their cognition. They know what the time they have their medication. What reminds you to take it? Did he have reminder, alarm, anything can remind him? Also, we ask him about the environment. Does anyone help you remember to take your medication? All this question can help us to assess the adherence. If he takes his medication in a proper way and proper time, anyone help him or assist him in taking his medication, or he just depend on himself or his memory. And a strategy to promote better adherence, how to improve adherence to the antipsychotic. There is many ways can help the physician to help his patient to be more adherent to their medication. For example, simplifying medication regimen, fewer medication, because if we prescribe a lot of medication with a frequent time, that the patient will be confused and maybe he will miss some tablet, especially if he take more than one medication and divide it in 3 times a day. So if we simplify the medication regimen, fewer medication, fewer pills, fewer daily dose, that can help the patient to be more adherent to the medication. Sometimes, because actually most of our patients, most of our medication can be taken once a day. That will be better if we prescribe it twice a day or 3 times a day, because that will help patient, because maybe he will forget some dose, and with the time he will be more prone for relapse. And second thing, active engagement of patient treatment planning. We ask him we are sharing decision with him. Some physicians, unfortunately, they just prescribe the medication and give it to the patient and ask him to go to the pharmacy to dispense the medication. It's better to ask the patient, what's the proper time for you? Do you prefer to take the medication in the morning or in the night? Do you prefer to take it in one dose? If we share them, if we make them to participate in this plan, they will be more adherent to their treatment. Third thing, using long-acting injectable antipsychotic. That actually long-acting injectable antipsychotic make a big shifting in our management. And instead of taking 1 tablet or 2 tablets once a day or twice a day or 3 times, now he will take just 1 injection a month or every 3 months with the Travicta. That will make our patient more adherent to their medication. As long-acting injectable injection can play a role in helping patients with schizophrenia remain adherent. Research indicates that the patient treated with long-acting injectable antipsychotic have decreased hospitalization 20 to 30% lower than for patients who receive equivalent oral formulation, and less use of emergency services because they will stable for long time. There is a study to show the perception of clinician versus patient toward long-acting injectable antipsychotic. Unfortunately, many physicians, they think if they start or if they prescribe depot injection or long-acting injection for the patient will refuse, or patient will not accept this idea. For as you see, the clinician perception, patients have refused or will refuse long-acting injectable antipsychotic. All patients will always prefer oral medication. This is the perception for most of the physician. Or patients are sufficiently adherent to oral medication, because actually this comes from poor assessment. If we doesn't assess the patient in a proper way, we think our patient is taking his medication in a proper way and he's okay. And on the other side, patient perception, my doctor has never informed me about long-acting injectable antipsychotic. And this answer from some patients, they said, no one told us about this choice, or there is another choice other than tablet. I may prefer long-acting injectable injection to oral treatment after trying that. Sometimes they will say, okay, let me try, and I will decide if I will continue on long-acting injectable antipsychotic or I will continue on tablet. And also, one of the patient perception, long-acting injectable antipsychotic may prevent relapse better than oral treatment. So if this will let us, what I mean, this means sometimes we don't, that means sometimes we don't spend a good time to educate the patient about the long-acting injection. If we give them all choices about tablet, the benefit and adverse effect, and injection about their benefit and adverse effect, some of them maybe will prefer the long-acting injection from the beginning, because most of us usually they consider the tablet as first choice, and later on they will discuss long-acting injectable antipsychotic with the patient. But we can discuss this issue with them from the beginning. Actually, the main concern for the patient and for the physician is side effects, because most of common occurring side effects for the patient, which is ABS, weight gain, insomnia, problem with concentration, powerless. How we deal with this side effect? Actually, it depends on a specific side effect. What side effect this patient has? Response to the medication, because sometimes some patients they have adverse effect, but at the same time they didn't have any benefit from this medication. Why I have to continue on this medication? In this way, I have to change this medication, not to treat the side effects. But on the other hand, sometimes some patients they get benefits from the medication, but at the same time they have side effect. In this way, in this situation, I have to educate the patient because now he's feeling good and he's better. But we need to deal with this side effect, because if we change the medication, maybe he will relapse. As we mentioned before, and we prefer to use multidisciplinary management. Not only focus on
Dr. Muhammad, sorry for the interruption, but you still have 2 minutes. Thank you.
Sorry?
Sorry for the interruption, but we still have 2 minutes left for this presentation.
I think this last slide, I think. Or,
Thank you. Thank you.
Comprehensive psychosexual treatment is important as an adjunctive to antipsychotic medication for all patients with schizophrenia. This intervention includes cognitive remediation, social skill training, CBT, family-based intervention. That was the last slide.
So thank you, Professor Al-Mukhawi, for a great session that actually summarized all the key messages regarding the management of schizophrenia and how we can increase adherence and how we can encourage our patient to stay on treatment for a long time despite feeling improvement. Thank you so much, and thank you for joining us despite your busy schedule and commitments. Dr. Al-Harbi will be answering all the questions on behalf of Professor Al-Mukhawi and on behalf of all the other speakers. So, Dr. Faris, can you join us again? Are you with us?
يا مرحبا. نعم. Yes,
Yeah.
I'm with.
Okay, so doctor, we have many questions. I will start with one of them. For how long can oral antipsychotic medication be continued while on long-acting antipsychotic injectables, the new ones such as Trivecta and Sustana?
Yes, it's a very good question. We remember that first, let's go back to Risperdal Consta. Usually we said Risperdal Consta, we need oral antipsychotic to be continued for at least 3 weeks with the injection. I'm talking about Risperdal Consta. Now we are moving to Invega Sustenna. Actually, we can start oral with the Invega Sustenna just to be sure that the patient not having hypersensitivity to medication, because if you didn't have sensitive, if you give the patient injection which is lasting for 1 month and your patient is sensitive, he may have serious side effect. So start with the oral medication just to ensure that the patient has no side effect, like you start Invega oral. After that, you can shift him to Invega immediately. Invega, the good thing about Invega, it can start from the first week. So from the first week, you can stop oral medication and shift him to Invega Sustenna, and you will show the improvement from you. Some patients, wallah, you see it from the first week. نيجي للترافيكتا. أصلاً الترافيكتا, you will not reach to the area or the trifecta unless you start for at least 4 months on Invega Sustenna. So during the period of Invega Sustenna, you are already, the patient didn't have any oral medication. So you shift him immediately to Trifecta without oral medication. You don't need oral medication from shifting from Invega Sustenna to Trifecta. But please don't start Trifecta. First, Invega Sustenna for at least 4 months, then shift him to Trifecta. If he is stable, especially in the last dose, it has to be the same.
Another question. Some antipsychotic may cause sexual depression. How to solve this problem?
Yes, then let's ask why he has sexual problem. Most likely because of high prolactinemia. So usually how it's happened, you give antipsychotic and the patient start to have high prolactinemia, and in the men you may have impotence or gynecomastia. In women you may have amenorrhea. So if the patient has sexual side effect, please, the first step, assess prolactin level. Most likely we see the prolactin level is high. When you have the patient, like a patient starting Invega Sustenna and you have high prolactin, what shall you do? First, exclude any other organic causes. So if there is no organic cause and you are sure it is high prolactinemia, it is from your medication, then you can use the lowest effective dose. So if the patient in 150, you can start 100 if the patient is stable. If it is still high prolactinemia, you can add aripiprazole, small dose. Also, you can give dopamine agonist like cabergoline or bromocriptine and watch the prolactin level until the prolactin level start to be low. If it is still be too high, even with dopamine agonist, then at that time you may consider shifting medication to other medication.
Thank you, Dr. Faris. Another question, does fasting affect mood and psychiatry? So do you usually recommend your patients suffering from mental health diseases, whether depression, schizophrenia, bipolar disease, to fast?
Fasting, you mean like Siyam?
Siyam, yes, Siyam.
fasting. First, alhamdulillah, we are not in Ramadan yet. In general, if the patient can tolerate fasting and the patient want to be fasting, yes, I don't mind. I may arrange his medication. But if the patient is suffering psychologically, like he is in schizophrenia or severe depression, we may not force him to fast. If that's his choice, we will help him. But if the patient has a severe psychiatric problem, ممكن يعذر من الله سبحانه وتعالى إنه ما يصوم، خاصة إذا كان affecting his cognitive function and he is not competent.
We have another question left from the past session. Do you give olanzapine in agitated children?
That question, I think it should be asked for child psychiatry. I'm not a child psychiatry.
Okay. Another question. The SSRIs and escitalopram for mild symptoms of depression, can they be used for a short period of time, then discontinue it completely, and then we monitor the patient? If he develops rebound depression, we can reinitiate them, or also they should be used for long period of time, for example, of 1 year, even if the patient has mild depression?
It's a very good question. Let's assume this is the first episode or the first time you start medication. We have three phases or three phases أو 3 مراحل. المرحلة الأولى, the first phase is therapeutic phase or المرحلة العلاجية. In that phase, you increase the medication gradually till you achieve remission. When you achieve remission, the first phase is ended, which is therapeutic phase. Then you will go to continuation phase. In continuation phase, the patient is okay. He has no symptoms, but you have to continue. أنا دائما أقول مرضاي هذه المرحلة الوقائية. So you have to continue. If it's first episode of depression, at least 6 months. If it is first episode or first treatment of anxiety, at least 1 year. Then we finish the second phase, which is continuation phase. We'll go third phase, which is discontinuation phase. You decrease the medication gradually over 3 to 6 months, then the patient, he may stop the medication, and after that you reassess. That's what I said for the first episode. But we don't use it just for 2-3 months and we stop the medication. In that case, most likely the patient will relapse. If the patient has 2 or 3 more episodes and the episode is severe, you may continue the medication for life.
Sure. And if there is any side effect from giving a patient an antidepressant for life, long-term side effect?
That depends on the medication. Let's assume you ask about escitalopram.
Yeah, SSRIs.
Yes, SSRI. Escitalopram, most likely the side effect, most of the side effect is temporary. It disappears within 4 to 6 weeks, especially GI symptoms, headache, etc. The symptoms that can continue, or the side effect that is continue, 2 things. Maybe weight gain. Second one, it is sexual side effect. Actually, the sexual side effect with SSRI, it's the main reason for discontinue the medication.
Yeah.
So, and sometimes the side effect itself, it is helpful for some patients. So some patients, they have premature ejaculation. You give him antidepressant, he will improve it from psychological point of view and from sexual point of view. But other medication, they may have symptoms and it can be treated. Like if he has impotence or decreased erection, we can give him, add some small dose of Cialis or something. So it can be manageable.
Yeah. Another question, do antipsychotic cause neurological side effects?
Generally speaking, very rare. There is case report, it can cause CVA or something, but this case report, but it's not the rule. Most likely it is safe.
And another question about safety, it seems that our audience their main concern is safety. So Ghaida is asking, do long period of treatment with mirtazapine affect the thyroid gland and can cause hypothyroidism?
There is case report. But most the mirtazapine, usually it's safe. And usually it's not affect the thyroid. There is case report about some incidents of hypothyroidism with mirtazapine, but usually it doesn't affect. The problem with mirtazapine for a long time is the weight gain. This is the main side effect of mirtazapine.
Okay. A final question about it's a little bit out of our topic, but Nimra is asking about adult hyperactivity. What is the preferred medicine for adult hyperactivity?
You mean ADD? Adult,
yeah, ADD, not ADHD.
Yes. Adult ADHD, we can use many medication actually. We can give him Strattera, which is atomoxetine. Also, we can sometimes, some patients, we can use with them a stimulant like methylphenidate, Concerta or something. But it can, النصيحة اللي ودنا ننصحها دائما للADD, don't, if we choose to use stimulant, don't use it daily. Use it only when you have something. يعني مثلا عندك اجتماع معلش خذه، عندك يوم صعب okay, but don't take it daily, because if you take a stimulant daily then you will develop tolerance, so then you have to increase the dose. So if you want to take it when you need it in ADD, or you can choose to use atomoxetine, which is Strattera. Also as a third line treatment we can use bupropion.
And in the same topic, she's asking an adult patient with ADD, and she has concomitant severe depression. She was prescribed escitalopram. However, she's refused to take her antidepressant, and she's not eating at all. So what do you recommend in this case? Do you recommend hospital admission, for example?
So let me summarize. Patient with
she's an ADD patient. She has severe depression. Yes. She was prescribed escitalopram, but the patient is refusing to take antidepressant. She's not accepting medication, and she's not eating any food. She's off. She doesn't have any. She's not eating well.
So let's see this patient. Is the not eating is affecting her health or not? Is the patient has psychotic symptoms or not? Is the patient competent to choose or to decide for herself or not? يعني إذا المريضة عندها psychosis, definitely admission, because psychosis and not eating, it may affect her life. Yeah. If she has psychosis and suicidal or homicidal, yes. Let's assume another scenario. ADD, but she has mild depression and she is competent. يعني ما الأهلية عندها, she is competent. I will not force her for admission, of course. But if it's affecting her life, if there is psychotic symptoms, yes, we can admit her.
Another question, they want your opinion about the use of venlafaxine in a patient with major depression.
Yes, as we mentioned that the first line treatment antidepressant, SSRI or SNRI. Venlafaxine, one of the SNRI. Yes, we can start him with the Effexor or venlafaxine. Yes.
Yeah. Another question: which antidepressant cause the most, or which antidepressant has as the most side effect is sexual dysfunction, and what is the least that cause sexual dysfunction?
That's a big question. Let's talk about SSRI. The most common to cause sexual side effect is paroxetine, which is Seroxat. But sometimes the patient has premature ejaculation. The best medication for him is Seroxat. So choosing the medication is tailored based on your patient. Regarding the least sexual side effect, it is bupropion, which is Wellbutrin, and Bristec, this venlafaxine. And from old medication, nortriptyline and disibramine.
A final question for the use of quetiapine. What are the side effects for the long-term use of quetiapine?
Quetiapine, the main side effect, it can cause sedation.
Yeah.
يعني المريض في البداية يحب الكوتيابين. يعني مثلا I'm extremely depressed and I start to give quetiapine with SSRI. After that ان الدبريشن يتحسن، فالنوم يتحسن، فالدبريشن فالكوتيابين يصير ثقيل علي، فابدا اخفف الجرعه. So sedation is the main side effect. The second main side effect, it is weight gain. It can cause weight gain. Third one, some people they complain إذا صحوا الصباح they feel like depressed. It help with depression, but some people it can cause early morning somnolence or dizziness. This is the main side effect. With increased weight, it can cause diabetes. You know, there's some studies about that.
Yeah. So those were all the questions. Thank you so much, Dr. Al-Harbi, for staying with us until the end, despite your busy schedule, and for answering all the questions. And with Dr. Al-Harbi, our mental health webinar comes to its end. Thank you for our esteemed speaker. Thank you for Jensen for sponsoring this activity. And the big thank you goes for you, our attendees, for staying with us until now. I want to remind you that you will receive your certificate of attendance by email within 1 week from today. And if you missed any part of this webinar, or you would like to revisit the lectures, you can check our IVPN NeuroPsychiatry library, where we post all the recordings and you have access to them. Follow us on our social media platforms and stay tuned for more activities in September. Keep your eyes on our page, as all the details about the upcoming activities, actually we have many of them, as you can see, will be announced very soon. And until we meet again, stay safe. Have a good night.